Mr. Mochloulis to talk to us today. He's a consultant head, neck, thyroid surgeon at Eastern North Herts NHS Trust, as well as being clinical director, I believe, of Eastern North Herts. And he's going to talk to us today on nerve monitoring in head and neck surgery. A couple of bits of housekeeping. Just make sure that you keep your microphones on mute to avoid any distracting background noise. As always, if you want to join up to our mailing list, please do. We are grandrounds.ent@gmail.com. I'll put that in the chat as well. And I'll also be putting out in the chat a little feedback form for you guys to fill in at some point. Any questions, if you pop them in the chat, and we'll interact with them as we go or towards the end, depending on how it fits in with the flow of the talk. Okay.
Thank you, and thanks for inviting me. My lecture is done in, as you can see, block capitals because it's 8 o'clock. So I thought it's a good idea for people to concentrate more. So my talk will be on nerve monitoring in ENT head and neck surgery. And specifically, I will concentrate on the two main nerves that we operate around, and that is the facial nerve and the vagus recurrent laryngeal nerve. My lecture will be starting with a bit of a history. I will talk about the principles of monitoring. We'll talk about latency and amplitude and waveform. And then we'll talk about facial nerve monitoring, thyroid monitoring, and also automatic periodic stimulation in thyroid surgery. It is always important to know a bit about the history. And interestingly enough, we didn't know that the muscular contractions can be connected to electricity. And it was only in 1791 that Luigi Galvani has published a paper which basically talks about electricity going through to muscles and causing contraction. And interestingly enough, for those that they are slightly older, you may all have had the opportunity to work in your school labs and look at those frogs' legs when you were stimulating them on a dead animal, and they will actually move, which obviously is an interesting experiment that we used to do when we were younger, maybe not anymore, to avoid cruelty to animals. So from 1791, it took another 50 years before Emile de Bois-Reymond has managed to measure the electricity and the electric activity in the muscle. And it took another probably 150 years until we have moved forward another step. And we then, in 1966, we managed to develop surface EMGs, which did not require invasive electrodes. And that was the way to obviously stimulate muscles around the face. So the technology has moved slowly to start with, but much faster thereafter. So in 1967, there was the first paper published that showed recorded ABRs on surface electrodes. And then it took another 20 years, in 88, when Lipton et al. Published a paper that showed that he used wire hooks placed in the vocal cords to monitor the recurrent laryngeal nerve. Obviously something that I wouldn't have thought was very comfortable for the patient. So 20 years later, it was the first published paper that showed that surface electrodes around the endotracheal tube can be used to monitor the recurrent laryngeal nerve. So it has taken quite a long time for us to be able to monitor the nerves that we're interested in the head and neck area. And obviously that shows in the amount of people that have taken on monitoring, which has taken a long time to happen and is still not universally accepted by all surgeons. Recently, we have developed what we call a vagus stimulation that allows a continuous loop of monitoring in the recurrent laryngeal nerve. And I will talk to you about it during the lecture. So why do we use monitoring? Obviously, we help to identify anatomical structures and especially the nerves we're looking for. But primarily, we want to prevent any injury or identify the injury so we can actually manage the patient accordingly. There is no doubt that training is very important and monitoring helps with the training. And lately, the medical legal aspect is very important. More and more of my patients come along and ask me on whether I use nerve monitoring without having a lot of knowledge, but because they were told that it is important to monitor those nerves. And I will talk to you about this during the lecture. So what can we monitor? Like any good surgeon, the most important thing is to know your anatomy. And of all the cranial nerves, as you can see here illustrated, we are really looking to monitor motor and mixed nerves. Specifically today, we will talk about facial nerve and the recurrent laryngeal nerve that comes out of the obviously vagus nerve. So the monitoring principle is that when you operate around a nerve or when you stimulate a nerve, that will send an electricity to the muscle, which will then contract, and that contraction can be picked up by your nerve monitor, so you know that the nerve is working. Before we talk about more of how we do it and everything else, you need to understand more about the EMG waveform and what it means. My experience is that when you use a machine, when you use a nerve monitor, it's very important to know what you're looking at. You need to know what is the screen shows and how it works. So the EMG waveform is made of the amplitude, which is the amount of electric activity picked up by the electrodes. So that means how many muscle fibers are contracted when you stimulate the nerve. The next thing you need to know about is the time it takes for the electric impulse to reach the muscle from the point that you stimulate the nerve, and that is called the latency. So if you look here, when you stimulate a nerve up on the top of the arm, it may take 7 seconds, but as you go closer to the area where you pick up the stimulation, the latency decreases to 5 seconds and then to 2 seconds. And I will talk to you about the importance of that in the next few slides. The other thing you need to know is that any nerve injury will slow the response, and therefore the latency will increase. And this is something that we need to know when we stimulate a nerve, when we are looking to actually stimulate and monitor during surgery. Now, the amplitude is, in effect, what it tells us is how much stimulation we need to give to a nerve so you can actually stimulate the fibers of the muscle that you are monitoring. So as you can see here, when you have 0 stimulation, you get no fibers stimulated. And then as you go down that list, with 8 milliamperes, you get some of the fibers stimulated, and then that comes out as on the right, and as you can see, as the volts, the millivolts, and then you stimulate more and even more, and more fibers are stimulated, and then you reach a point where all the fibers have been stimulated. And we know, and we have calculated that, especially in the recurrent laryngeal nerve, 1 milliampere of stimulation will actually stimulate most of the fibers of the recurrent laryngeal nerve. So any more any increase in the stimulation will not stimulate more fibers. So there's no need to stimulate any more of those fibers. Now, what it can do, though, it can actually start stimulating structures around the nerve. So you may have a case where you're trying to stimulate the nerve and it's not stimulating. And then by increasing the amount of milliamperes you're using, you start stimulating the esophagus, and that will give you the false idea that the nerve is intact. So it is very important to know those principles when you're looking for in a screen to see on whether you get a stimulating result in a nerve that you're monitoring. So for those that they speak French, you have here a monitor that tell us the right and the left vocal cord. And how do we know that this is the right and the left, other than if we can speak French, is the fact that if you look at the latency, the left latency is slightly longer than the right one. And that is because obviously the left nerve has a longer route than the right one. So when you look in the screen and you look at this very nice response here on the right and the left recurrent laryngeal nerve, you can see first the latency and know on whether you have a right or a left chord that you're stimulating. You look at the amplitude and you look at the wave form. You need to have a biphasic waveform, which is very important, so you can have a nice stimulation. Now, the other thing that is very important, and is not only important because it tells you which nerve you're stimulating, is also important in non-recurrent laryngeal nerves. So when you stimulate the right recurrent laryngeal nerve, you can see that the latency is 2.2 milliseconds. On the left is 2.4 milliseconds, because obviously the nerve is longer. If you have a non-recurrent on the right side or on the left, those numbers will be smaller. So before you even try to identify a non-recurrent nerve, if you have really stimulated, if you have a nerve monitoring on, you can identify that you have got a non-recurrent nerve. The same information you can get if you have exposed the vagus and you're stimulating the vagus nerve. You can see here that on the right vagus, the distance between the vagus and the larynx will take about 3.8 milliseconds. And on the left, it will take 6.5 milliseconds, again, because of the long distance of the left recurrent laryngeal nerve. Again, very important information that you need to have, and you need to know when you're looking to stimulate, to use a monitor. And you can get all that information on the screen when you are looking to start an operation or during the operation. So this is a slide that I always put here, which in fact is quite interesting, because this is a study that was done, I think now maybe about 7 years ago, 6, 7 years ago. And only 51% of UK consultants performing primary surgery use nerve monitoring. Interestingly enough, 90% they said they were using it for parotid surgery, and only 24% of surgeons performing routine thyroid surgery are using nerve monitor. So it's not something that everybody is using, and it always surprises me and continues to surprise me that it hasn't been adopted universally by everybody. And that taking into account that recurrent laryngeal nerve palsy has a very varied percentage in different studies, between 3 and 8%, sometimes more. And those figures do not, I think, show the real number of patients that they get recurrent laryngeal nerve palsy. And there's definitely no study for the external laryngeal nerve. So we are operating on patients and causing complications without even knowing and without understanding the fact that by using nerve monitoring, we can possibly reduce those complications. So there are different devices, and all of them, they do very similar things. Um, I will start with parotid and mastoid surgery. So what we're really looking is we're looking for monitoring the facial nerve. We all know the complications that a facial nerve palsy will cause to the patient and the morbidity associated with it. So the idea of doing surgery around the nerve or close to the nerve without nerve monitoring, to me, is still baffling. And I think that for the young generation, there should be no question about using a nerve monitor. The principles before you start doing facial nerve monitoring is to follow two or three things that I've got here. Obviously, you need to make sure your anesthetist will do a non-paralysis anesthesia. There's no point of doing anything to monitor a nerve if the patient is paralyzed. Obviously, you need to make sure that the nerve is intact before parotid or mastoid surgery, and obviously that the organ that the nerve is supplying is functioning. And then you need to make sure that your equipment is functioning, and that's the other thing that you always have to look at. And lastly, and I think is the most important thing, is to know the right interpretation of what the machine tells you. There's no point of looking at a machine or putting a machine on just for the sake of it, which is quite commonly seen. And I have been to different places and seen consultants and trainees struggling to interpret what the nerve monitor shows. So the facial nerve can have different forms of injury that we can cause. We can cause a complete transection of the nerve, which is not common, but it can happen. But all the others are much more common and more easily easily present during the surgery in the mastoid area and the parotid area. Heat damage, mechanical damage, bruising, direct pressure, traction, devascularization of the nerve, and obviously local anesthesia. Sometimes when you put a local anesthetic close to the nerve, you may have a sort of a timing up to an hour, sometimes more, where the nerve will not be working. So all those things have to be taken into consideration before you start monitoring the nerve. So let's say you have a facial nerve damage. The first thing to see is that where's the damage been caused? And when we're talking about mastoid ear surgery, usually if there is a damage to the facial nerve, all the branches would be affected. If you have parotid surgery and you damage the main trunk, then again, you will have all branches affected. But during parotid surgery or submandibular gland surgery, you can have selected branch affected. And that is related to a specific manipulation or when you operate around a specific branch of the nerve to remove a tumor, where you can actually cause injury to the nerve. So we all know that if we do get a parotid a facial nerve injury, we have to use the House-Brackman classification, and we need to look at how much damage you have caused. And there is no doubt that you never want to see 6 or 5, but you expect that 1, 2, 3, and 4 will usually improve in time. And that is very important to identify early and then document that in the patient's notes. So when you go back, you can review and see the improvement. Now, this is when you do what we call an active or static nerve monitoring. and that is by identifying the facial nerve and then stimulating and making sure that it's working. And the new thing that is coming along is what we call a continuous facial nerve monitoring. So that means that you can continuously measure the function of the facial nerve. And a new monitor that is coming along from Medtronic and maybe from the other companies will allow that. So you will get a picture similar to that on your monitor. So you will have the frontalis, orbicularis, oculi, oris, and mentalis. And you can then stimulate and have a continuous monitoring in one of those branches. And you can choose the branch you want, especially if you're working around that branch. And that will give you, as you can see on the dots on the right, a continuous monitor of the nerve during your dissection. So you know that there is no damage caused. And you can see that the demonstration, the small probe is attached to the main tract of the facial nerve, and the nerve is stimulated every 4 to 6 seconds. And you know that the nerve is intact during your dissection. And this will be the new thing that will be coming in parotid surgery in the future. And that will allow us, together with what I will discuss with you soon, in the recurrent laryngeal nerve, to have continuous intraoperative monitoring of the facial nerve, which then will give you the ability to know for a fact that the nerve will be working at the end of the procedure. Thyroid surgery. Recurrent laryngeal damage, by far the most serious of thyroid surgery complications. And why I'm saying that is because in reality, most of the surgery we do in thyroid is benign surgery. It involves all groups of patients, but it involves young patients, patients that they have benign disease, and therefore permanent recurrent laryngeal nerve damage can cause a long-term morbidity that we have for years underestimated. Obviously, we need to know that bilateral vocal cord palsy can cause airway obstruction and death, and that again has to be taken very seriously. And external laryngeal nerve damage has to be taken very seriously as well, because not only it can affect the voice speech, but also it can affect the sensation, as it is the recurrent laryngeal nerve, the sensation of the larynx, and that could could lead to long-term complications when it comes to both voice and swallowing. So again, when we're talking about managing and monitoring and recurrent laryngeal nerve, we need to know about the anatomy. And you all very well know the anatomy of the recurrent laryngeal nerve and the superior laryngeal nerve that has, as you can see, the internal laryngeal branch and the external laryngeal branch. They're coming off the vagus nerve, and you know that they supply different parts of the larynx. I think it's very important to know that the motor and sensory supply of the different nerves in the larynx. And that is because different damage can cause different outcomes when it comes to the patient afterwards. So how we actually measure nerve damage, and I will actually clearly tell you that out of those things, up to recently, most thyroid surgeons did none. Nobody will do a nasoendoscopy. Most surgeons will do mirror indirect laryngoscopy before the surgery, and definitely never after the surgery. Very few people will do a video stroboscopy when they have a case of a patient that has altered voice after surgery. And I would have to highlight the problems that some patients have with damage of the recurrent and the external branch of the external laryngeal nerve to the swallowing and the sensation of a feeling of a lump in the throat. and the quality of the voice. And I see a lot of patients that they refer to me not only because of recurrent laryngeal nerve damage, but also a lot of the times they come in with vocal cords that they're normal and on nasal endoscopy are working fine, but the patients have symptoms of change in the quality of voice, or sensation of a lump in their throat, or sensation of difficulty with the swallowing. So all those measures to actually look at the voice outcomes are very important if you're a thyroid surgeon. You need to use all of those and make sure that you consent the patient adequately before the surgery. How do you damage the recurrent laryngeal nerve? Very easily. You know, in my experience, it's very easy to damage the nerve, and you can have all sorts of different types of injury. Obviously, the worst of all is transection, but you can have a partial section. Hit injury and stretch injury are very common. When you manipulate the thyroid, you can get a tension injury, and then you can get devascularization if you skeletonize the nerve completely. And one common injury is the pressure injury, when you use a clip to actually dissect above the nerve, and without knowing, you press the nerve, you can actually cause press injury that again will lead to at least temporary vocal cord palsy. So there's a lot of things that can go wrong here. So I see no reason why we shouldn't actually try and protect the nerve, or at least know what happened to it during surgery. So nerve monitoring is very important. You will need to use one of those tubes with the electrodes, and you need to actually know what you're looking for. And you're looking for the amplitude and the latency. And when you establish that, you can see here on the left, on the right hand side of the screen, you've got the left vocal cord that we are stimulating with an amplitude of 2150. And we can see that it is the left because we are stimulating the left vagus nerve. So you can see straight away the latency is 6.8 milliseconds. That is very important to know. So you know you're in the right side. So you don't only rely on you looking at it, but you also know that the machine is still working when you are doing your nerve monitoring. So you get a nice demonstration of the nerve working. And you can do that by intermittently stimulating the nerve. But that doesn't always work. So what it usually proves is conductivity of the stimulated nerve segment towards the muscle. And you can do that by using the probe and every now and then stimulate the nerve. But we know for a fact that following an iatrogenic lesion of the recurrent laryngeal nerve in porcine model, the distal nerve segment shows unchanged amplitude of the electrophysiological response for a period of up to an hour after you've transected the nerve. So you can get the idea that your nerve is working when you have already transected the nerve. And then that will give you the false assumption of an anatomical intact nerve when that is not working. So it is very important to know that yes, intermittent nerve monitoring is good. It's good to identify the nerve, but it doesn't actually tell you that at the end of the procedure, the nerve is working as is and is intact, and it will actually lead to a normal vocal cord function afterwards. The other thing that you need to be aware of is that, let's say you have a nerve injury in the middle of the root of the recurrent laryngeal nerve on the right, as you can see here. So if you stimulate above on that circle that I've got here, and you stimulate the nerve above, then you will get a good stimulation, because on the intermittent nerve stimulation, that nerve will still be stimulating at that area. So it will give you the false assumption that there hasn't been a heat damage or traction or a pressure on the nerve, and therefore you wouldn't know whether the nerve is working 100%. For that reason, 10 years ago now, we started using what we call a vagal nerve monitoring. The whole idea is that you have a loop stimulation from the vagus all the way to the nerve and all the way to the muscles, and that will give you a loop of stimulation. And you can do that during the surgery, and that would probably reduce the amount of damage you can cause in the nerve, but it also alter the way you are using and you are operating during surgery. And I will explain. So the whole idea is that you've got a probe like this, and you can see the little probe there, which is it's got a stimulation at the end of it. And what we do is we dissect about 1.5 centimeters or 2 centimeters of the vagus nerve in the carotid sheath, and we attach that probe into that vagus nerve. And you can see another picture here, very well demonstrated. We have just dissected 2 centimeters of the nerve, and you attach the probe. So that probe will actually apply stimulation on the vagus nerve every 2 to 4 seconds, depending how often you want to do. So you're almost having an sort of a continuous EMG of your recurrent laryngeal nerve. So it's called automatic periodic stimulation, and the wave form and the amplitude you want to obtain is usually above 100 millivolt. We now know that we usually will get 500 millivolt and above. That means that you have good connection over the tube, and you can actually pick up enough fibers from the muscle of the vocal cords that will actually give you a good idea that the cords are stimulating. So how the system is designed in such a manner that any decrease of 50% in the nerve conduction, which is shown as an amplitude drop, that will set an alarm, and that will actually put you in a position where you will know that is more than likely because of some temporary damage or traction of the nerve, you are not stimulating enough fibers. So that will, so the alarm is set before or after you identify the recurrent laryngeal nerve, and then you put the probe in the vagus nerve, and you know then that every time you move the larynx, you move the trachea, you move the thyroid gland, or you are very close to the nerve, there's a possibility that you may cause a temporary traction damage of the nerve, and then you have to readjust the way you operate so you actually will not cause further damage to the nerve. And you can see here quite a good demonstration of that. So you've got latency on the top of 3.75 and the amplitude at the bottom. And you can see that when we started the operation, you have a very good amplitude. And then when I started using or manipulating the muscle, the amplitude dropped below 50%. And then I have to do something about it. So I have to use less traction, stay away from the nerve, make sure that I don't use a heat energy device in the nerve. And then very quickly, you can see that the nerve amplitude is going further up, and again above the minus 50%. And at the end of the procedure is above the minus 50%. So I know that for a fact that at the end of the procedure, this nerve will be working and the recurrent laryngeal nerve will not be damaged. So as you can see, what it does is it allows you to have an immediate way of solving a problem when you actually you have a reduced signal or lost the signal, and therefore it will prevent you from having either a permanent recurrent laryngeal nerve injury or a temporary or a paresis or temporary injury to the recurrent laryngeal nerve. So we have been using that for the last 7 or 8 years. So we thought we will actually do a study to see on whether this is working and on whether it will help us to identify those injuries. So we looked at between 2014 and 16, we looked at a retrospective review of all thyroidectomies using APS. So we used the saved electronic data that I will show you in a minute, patient's demographic, the pathology, and the incidence of the recurrent laryngeal nerve immobility, which is assessed by flexible nasoendoscopy, and obviously the permanent damage to the recurrent laryngeal nerve. So as you can see here, we have a different type of patients, different ages, from a very young of 27 to 86. And the pathology is, as you can see, the typical pathology of a high volume thyroid surgeon with a lot of patients that have multinodular goiter, papillary carcinoma, or other types of thyroid cancer, and Graves' disease and thyroiditis. So we looked at the outcomes, and first of all, the machine is quite good to tell us how long the operation takes. So you can see on average, from the minute that we place the APS nerve monitor probe to the vagus nerve, it's taking about 17 minutes to do a resection. That means to dissect the lobe of the thyroid, and that is of course before you achieve hemostasis and close the wound. So the resection on average took 17 minutes for each side. So we have 2.3% vocal cord palsy, and you can see the different cases. And interestingly enough, we had a very, very low neuropraxia rate. So only 2 patients developed neuropraxia. And in this study, we had no vagal nerve injury. So what we get a lot of information using a nerve monitor. One of them is that little diagram you can see here. On the left, we have a nerve that seems to be working well and is intact. And that is because all the big columns are the back of that diagram. That means the amplitude in most of the time that we operated was above 75%, and the latency was most of the times about 100% or less. On the right side, you can see we have some columns that they are onto the front of the screen, and that tells us that the latency has increased and the amplitude has reduced less than 50% of the medium latent amplitude that we wanted. So you can see that we looked at the outcomes, and we can see that intraoperatively, an amplitude of less than 50% occurs more frequently in immobile vocal cord group than in the normal group. So we know for a fact, the minute your amplitude goes below 50%, you're putting that vocal cord and then that nerve at risk. So you need to make whatever effort you can to reduce that reduction in amplitude. So in our series, we found at the end that if we only perform flexible nasoendoscopy on those patients that they had amplitude of less than 40%, we would have detected all cases of vocal cord immobility and maybe avoided 214 unnecessary scopes. Also, we would have known for a fact that we had if the amplitude was less than 40%, we had some nerves that they are in danger. And sometimes you can't avoid that if you have a patient with cancer. But what we can do is you can then easily start making discussions on whether you should go to the other side and operate on the other side if you feel that one of the nerves are in danger. And this is a big question that we haven't yet answered, but there's definitely something we have to look in the future. The other thing we obviously found is that we had no cases of hemodynamic instabilities secondary to vagal stimulation, no injury of the carotid artery or the internal jugular vein, and we can see the permanent and temporary palsy rate here. So overall, we were satisfied that using a continuous nerve monitoring was important for us to know what a nerve will do after we finish the operation, but also to stop us from damaging more nerves or definitely causing temporary paresis of the vocal cord in most of our cases. Now, the question though is that why would we do another procedure when we do a thyroid operation and we open the neck and then we have to open the carotid sheath and find the vagus? Is that increasing the number, the amount of time we need to take to do an operation? And what about causing any damage? And you can see here, obviously, we have not caused any damage to the vagal nerve or the carotid sheath structures, but we thought we will actually demonstrate that even better by using myself and one of my registrars as guinea pigs. So we thought, why don't we do a study where we will look at those potential contraindications, additional operating time, potential learning curve, risks of vagal neuropraxia if it's done not by a very experienced surgeon, and also the risk of causing autonomic instability. So I thought I will ask my registrar, who came with a very little knowledge of how to do APS, or in fact never done APS before. So we did 31 consecutive cases, and the registrar and myself did the cases, but some of them he did on his own, some under my supervision. So you can see here on the 14 nerves that we looked at, the different stages of the operation. So we measured, first stage was raising the flap and putting the Joel's retractor. Second stage is finding and dissecting the vagus nerve and placing the electrode. And you see here that the average time was about 3 to 5 minutes. Then the stage 3 was the dissection of the lobe, and stage 4 was hemostasis and closure. So on those 40 cases, we looked at how did the trainee do and how the consultant did. So I, on average, did 10 cases. I did 10 cases, and on average, it took me about 3.1 minutes to do the dissection of the carotid sheath and place the probe. And the trainee, interestingly enough, obviously a very good trainer and an average trainee, he managed, I'm joking, he managed to do it in about an average of 4.8 minutes. So not a big difference. And interestingly enough, also, the learning curve was not that bad. It started between 4.5 seconds to 7 minutes, and gradually went down. And you can see also that some of the cases he did with me not being scrubbed. So obviously there is no question that a trainee cannot be trained to use the vagus monitoring, and there is clear evidence on this small study that is completely safe to use continuous monitoring to monitor the nerve, and the additional time is very little compared with the benefits that you get using the continuous nerve monitoring. And I will conclude by saying those 5 things. My view is that nerve monitoring should be always used when a nerve, a motor nerve, is possible to be damaged during any surgery we do in the head and neck. If it is used in one patient, it should be used in all patients. I have had many cases of people and surgeons and units where they say that they only use the nerve monitor in difficult cases. And my experience is that it is so difficult to do a difficult case that having the additional problems of making a nerve monitor to work on those difficult cases will probably be counterproductive. So in my experience, either you use it in all patients or no patients. And the next one is that if available and you haven't used it, there are always serious medical legal questions raised. And there's more and more often that I see patients that they will sue when a nerve monitor was available in their unit where they were operated and nobody was using the monitor. I believe it's perfect for training. And the last thing I'd say is that none of us is perfect. I don't think any surgeon can say they're perfect. So any assistant is definitely welcomed. So I believe that using nerve monitoring is a very good addition, and technology should always be embraced and used by all of us, especially you, the younger generation. Thank you very much.
Thank you very much. That was a really excellent, very interesting talk. Just waiting to see if there are any messages with some questions coming through. I've not personally had any, but I don't know if Rajuta's had anything.
I've actually had loads, so I just need, well, not loads, but I've had a few, Mr. Mochloulis. You're not in a rush to leave at 9 on the dot. If you've got time, you can do questions. Super. Okay. One of the first questions came up sort of twice actually, and it's related to the use of the nerve monitor. And I suppose, I mean, it's been phrased slightly two ways, too differently, but essentially they're asking about the risk of neuropraxia from the actual monitoring itself. Is there anything that people should be concerned about with that, particularly with the continuous monitoring? And one other version of that question was if the latency is lower than expected, should you be more worried about how you can monitor for that sort of neuropraxia? Okay,
the answer to the first question, the studies that were done, and I know they were done on animal models, they had a limit of 10 hours of continuous stimulation of the recurrent laryngeal nerve with no paralysis or paresis or damage to that nerve. Okay, now I wouldn't have expected anybody to use a continuous nerve monitor for 10 hours. And definitely we never had any case of paresis of the nerve because of long use of the continuous monitor. So that's the answer to that. And the other answer was what? What did you say?
It went, you know, if the latency is lower, you mentioned that you can use it as a sign of the anatomy of the nerve. But if the latency
is low, that means that there must be an anatomical variation. And I think that is important. If the nerve is intact, so if it's low, that means that it's shorter. So shorter latency means that there will be a definite anatomical variation. So when a nerve is abnormally damaged, the latency increases. Okay. If at the beginning the latency is less, that means that you have to carefully look at that nerve and see on whether there is an anatomical non-recurrent variation to that nerve. And that is a very good way of knowing before you even start the operation, where to look for the nerve.
Brilliant. Thank you so much. The next question is related to facial nerve monitoring. Are you aware of any work towards being able to have continuous monitoring in mastoid surgery? And in that case, I suppose they're asking, where would you place the continuous monitor? Would it have to be on, would you have to dissect out the main branch from the parotid to do that, or is there any way you could place it in the mastoid?
So there's no discussion, and I have not seen anybody publishing or doing anything, because in reality, the only way you can do that is if you actually skeletonize the facial nerve and place the monitor on the facial nerve in the mastoid.
Yeah.
I think the risk of doing that is too great to actually do it at the moment. Now, what will be coming in the near future is, instead of the probe that I showed you, they are working on developing almost like a small sticker. It will be like a sticking thing that you will actually stick on the nerve, and which will not be encasing the facial nerve, and that will then be an easier way of continuously monitoring the nerve in the mastoid, because then what you can do is you can maybe skeletonize one very small portion of the facial nerve and apply the sticky bit of the continuous probe, and then you can have a continuous monitor of the nerve.
That sounds very exciting. I suspect the person who asked the question was thinking about the equivalent of the extra step that you have in the continuous monitoring of finding the vagus. What would be your equivalent in the facial if you're doing it for the mastoid? So that's really interesting.
And I know that some surgeons do actually expose part of the facial nerve, especially when they do a combined approach tympanoplasty, or expose the canal. I mean, I think that maybe is a bit dangerous to actually expose the nerve itself and decompress the nerve and the canal, and maybe you're putting it in more danger. But there may be in the future a way of maybe applying a probe through the, on top of the mastoid, of the canal, basically, of the bony canal, and being able to get a continuous monitoring through that. I don't think there's been enough studies done, and I haven't heard of anybody doing it at the moment.
We'll watch the space. Let's see what comes.
We need an otologist to get on with it.
There are some in the audience, so maybe they're going to go make a $1 million idea.
Yes.
There was a question here about, is there anything out there about comparing complication rates with monitoring versus without monitoring? I suspect. I mean,
so the latest study.
Slides.
Okay, the latest study, which actually positively confirms that using nerve monitoring has a better outcomes, has just come out, I think, from Germany. They looked at 14,000 consecutive thyroid cases, and there's a significant statistical outcome that suggests that nerve monitoring reduces vocal cord palsy.
Brilliant, that's really helpful. I have another question here, and I suspect it's about, I don't know if it means about pre-op or post-op, but it says, is there a diagnostic test for external laryngeal nerve injury, especially if the endoscopy is normal? But you did mention there's no active testing of the
monitoring, but you should be actually making sure that you're not damaging the nerve. The only thing I can say is that you can probably ask the speech therapy to do voice analysis, but you have to be doing that before and after surgery. So I think at the moment we haven't got, because then you have to do a voice analysis before in every patient, and then voice analysis on every patient afterwards. And I don't think that we're doing it at the moment.
Thank you. And my last question it's a more of a clinical based one that's come through. There's a question here about your practice regarding the use of steroids. I presume specific to parotid, really, but if you know that anatomically and based on the monitoring electronically, the facial nerve is intact, but there is a degree of palsy post-operatively, do you have a practice with regards to the use of steroids? I think is what they're trying to ask.
Okay, I'll tell you what I do. I'll do 2 or 3 things. Both I'll tell you on the parotid and the thyroid,
Yeah.
the recurrent laryngeal. All patients have a preoperative or perioperative dose of IV dexamethasone, and usually they will not have any more steroids if I am not worried. Okay. When it comes to facial nerve paralysis, if I know that the nerve is stimulating, I will not use steroids. If I think there is a lot of traction, then I will use 2 or 3 days of postoperative steroid treatment.
Okay, brilliant.
When it comes to the recurrent laryngeal nerve, for the people that are interested, when I use the continuous nerve monitoring and I am worried, what I do is I wait. If I worry about the nerve being pushed, damaged, I will actually stop the operation and wait, maybe do the other side, or wait for 5-10 minutes. If I think it's a thermal injury, I will apply a cold a swab with saline in it and wait for 5-10 minutes. Most of the mild thermal injury patients will actually regain an amplitude which will be acceptable. And in a lot of the patients that I've seen that they're regaining that, if you do that, they will get adequate amplitude, so you can actually, for example, go to the other side without worrying.
That's really brilliant. That's really helpful. Those are all the questions I have through. Kira, did you have any more?
No, I think they were all sent directly to you, Rajuta. Thank you again for talking to us, Mr. Mochloulis. If people could take a moment to fill in the feedback form, I have popped it in the chat again. And yes, thank you so much.
Can I also say that I'm very happy when things are over with COVID, that any of you, if you want to come along and see how we do it, I'd be more than happy to get you along, even for a day, to spend a day seeing how we do continuous monitoring. And also, when things are better after COVID, we run twice a year continuous nerve monitoring course, sponsored by Medtronic, which they pay for you to come along and attend. So if you're interested, when things are better, I'd be more than happy for any of you to come along. But use the technology.
That sounds amazing. Thanks, everybody.
And thank you again, Mr. Mochloulis. That was absolutely fantastic.
No problem. Thank you.
Good evening. Bye.